Okay, so first at the outset I would like to thank G-SPARC for giving me the opportunity to be a part of the talk today. I'm as much excited as I'm scared to give the talk now. I'm a clinician. As you have seen the previous speakers, the chair have minced no words in criticizing clinicians in their approach to infections. So delivering a talk looks a little scary to me, but I'll try to do what best I can. Before I start, I would like to know about the audience here. I've asked this question when I was asked to do this talk also, but I did not get a clear answer. Are there any dialysis technicians here? Okay. Dialysis nurses? Nobody. So the exposure and understanding to dialysis is little, so I'll confine my talk to basics of what happens during dialysis and why there is an infection risk. See, this talk of 20 minutes cannot be exhaustive covering all the topics. My idea is to give 3 or 4 take-home points to get an understanding of what is happening during dialysis and why do these patients get these infections. Okay, so the task is to discuss on infection prevention and control in dialysis units, ensuring safe and quality care for patients. So as I've told, I'm a clinician, not an academician, so don't expect a lot of data. I would only give you a few clinical scenarios and what is happening to our patients. So I'll start with a case. This is a 65-year-old female with multiple access failure. So to give a basic outlook, dialysis patients require access where the blood flow is 200 to 250 mL per minute. So that can happen either through a central catheter or an AV fistula. So that is, she had multiple peripheral vascular failure, so she's on a tunnel dialysis catheter on the left side. Now she left our unit to a smaller unit and then presented 4 weeks later with fever and chills during dialysis. That means that the catheter is infected now. So she is relatively asymptomatic between episodes as is expected, and she had poor response to IV antibiotics, Acinetobacter grew in culture, and catheter could not be salvaged. This is a routine story in many dialysis units. The problem is catheter is considered to be an essential evil. It is a lifeline to these patients. Without this, there's no life for them. So if the catheter gets infected, particularly in patients who have multiple vascular failure, losing a precious access creates a lot of pressure for the consultant as well as the treating patient. So if catheter could not be salvaged, we had to put the patient on femoral catheter, reducing the quality of life of the patient significantly. So what is the reason for such increased risk of infections in dialysis unit? Immunosuppressed patients, frequent vascular punctures, vascular access catheters in situ, surface contact with machines, reuse of dialyzers, and healthcare personnel managing multiple patients. You might have seen a lot of dialysis units with healthcare personnel. It's not that every patient will have a separate nurse and a separate technician. So few technicians manage multiple patients and multiple sessions in a day. Unlike an ICU where a set of 6 or 10 patients are there and they won't change. So it's a frequently a unit with a lot of inflow and outflow. The most important problem is the water. So this is what happens in dialysis for a basic understanding. So the blood from the patient flows through the pump and then through the dialyzer. The small vertical chamber that you see is the dialyzer, through which the blood is returned back to the patient. That is the blood circuit. On the other side, you see the water circuit where the dialysate flows in a counter current direction, in an opposite direction to the blood flow. So that is the basic principle of dialysis. Now, this is what is essential for removing the toxins and doing an ultrafiltration in patients. So this is the circuit of a standard dialysis. So the infections revolve around these two systems. One is the blood system of the patient, the other one is the water system of the dialysis. So this slide has already been projected earlier by my earlier speaker. So these are the water standards that are recommended to maintain in a dialysis unit. So how to reduce the risk? In addition to the standard precautions, dialysis unit precautions are also to be followed. I'll not be discussing the standard precautions because that is probably as the chair has pointed out, I'm not probably the right person to speak about that, but I'll move on to the dialysis unit precautions. So I've put it under 8 headings. The first 3 are on the water column side, that is the water treatment, dialysis machine and the dialyzer use. The next two are on the patient's blood circuit side, catheter care and AV fistula. The last three are most of the common problems in any ICUs, including multi-dose vials, vaccination and isolation procedures. Coming to the water treatment. Okay, so this is a water treatment unit. So I will not go into details to confuse you much further. It is enough to understand that the water treatment unit has three main parts. The pre-treatment, where the particulate matter and the elements like chlorine and chloramine are removed. The primary treatment, which is what you have in most of your home units also, the reverse osmosis with ultraviolet exposure. And the last one is distribution and monitoring. And like what has been pointed out again by my earlier speaker, most of the units have outsourced the primary treatment of water to external sources. Our unit is managed by Fresenius, so in many units the quality of water is relatively well maintained. The problem comes somewhere else. So this is our water treatment unit. A word of caution that this has been taken at the time of construction of the unit. So this is the pre-treatment part. This is the RO part. We have a double RO. So 2 ROs, and then there is a storage tank. The problem is not with water purification in most units. The problem comes now. The water distribution, that's where most of the risk for contamination happens. As you can see, this is the recommendations have been that water treatment should not include these kind of acute bends, right angle bends, should not include places where water can have stasis. The recommendation is to use these pipes, which are called the PEX pipes. These pipes have a smooth curves. These PEX pipes lead to less risk of infection due to less stasis in the patients. So the units have mostly moved on to the traditional plastic or the PVC medical grade plastic to these kind of PEX pipes. So these are the recommendations from CDC regarding that. As I told, my idea is only to give one point of clarity regarding each step. I don't want to confuse by adding too many things of what needs to be done regarding infection prevention. The second one is dialysis machine. So this is a patient, typical patient in our unit who is completing his dialysis and walking back. So this is again is a video for demonstration. This is not what happens in our unit. Our unit follows the protocols thoroughly. As you can see, the healthcare personnel there is just cleaning the bed and inviting the next patient. So what has to be done after each dialysis session is important. The most important thing is changing the linen, cleaning the surfaces with medical grade bleach, including the bed surfaces and the dialysis machine itself. So the dialysis machine cleaning involves these three. I'd like to put it in a more, see, when we try to teach our HCPs, it is always our staff, it is always better to use rhyming or rhythmic sentences so that they remember. So what we teach them is to rinse and wipe after every rise and wave. When the patient rises and waves you by, you have to rinse. That is rinse the machine, that is the heat disinfection of the machine, as well as wipe the surfaces. Descale daily. Descalation is actually using citric acid to remove the scales that are formed in the internal hydraulics of the machine. That has to be done daily. And the third one is bleaching of the machine, again to clean the proper disinfection of the internal hydraulics. That has to be done by bleach. Next is the dialyzer reuse. We don't have a video for dialyzer reuse. Our unit does not follow the policy of dialyzer reuse. Dialyzer reuse can be safely done, and it's practiced by many units with enough hygiene and with enough safety. 2-3 things that have to be remembered in dialyzer reuse is there should be a clear reuse area and a clear clean area. So it is not that you mix up, you clean the dialyzer and store it at the same place. There should be a clean area separate and a reuse area. The cleaning involves rinsing the dialyzer thoroughly and locking it with a disinfectant. The commonly used is the peracetic acid with peroxide. And then when it is brought back to reuse, it should be thoroughly rinsed. The problem is not just about preventing infections, but also the problem with the disinfectants that are using. If you leave traces of the disinfectant within the dialyzer, the patient can get a dialyzer reactions. So thoroughly rinsing it again and just checking it with an acid, with a pH tester to see whether there is any residue of disinfectant is there in the dialyzer is important. Catheter care. Here again is a small video to demonstrate the common errors. As you can see, the blood lines in the catheter already have traces of blood in it, which should not be there if it has been properly flushed. And the dialysis nurse is trying to directly connect the tubings to the catheter without cleaning the hub. What should be ideally done? I don't know what I'm doing now. Yeah, so this is what has to be done. Cleaning the hub with either an alcohol or a chlorhexidine gas before connecting the tubings makes a lot of difference. In our unit, the risk of infections have significantly come down after following just these 3 practices. So what we teach the staff is to rub the hub, that is cleaning the hub before connecting, wrap the strap. That means once the tubing is connected, we wrap that with a chlorhexidine gauze. During the 4 hours of dialysis, it's completely wrapped. And for the risky people, that means for those who have a very, very precious catheter, for those whose catheter is a lifeline, for those who had a previous episode of catheter-related bloodstream infection, we give them an antibiotic lock in these patients with gentamicin. Fistula cannulation. Actually, I've asked my staff to do a peripheral to central cleaning to make a recording, but unfortunately or fortunately, they are so used that they did a proper cleaning only in this patient. So we could not record the error that has to be done. So this is a cleaning that is going on from the central to periphery. Make no mistake that it often happens that technicians clean from one side to the other side. That central to peripheral part of the cleaning is not practiced in many units. So that kind of cleaning should be taken care of to prevent risk of infections. So clean the area with appropriate antiseptic using circular motion starting from the center moving outward. This is another common mistake which we thought should be corrected in dialysis units. So this is regarding the multi-dose vials. So multi-dose vials have gone out of practice in many units, but in dialysis this remains a problem because each heparin vial comes as 25,000 units. An average dialysis uses somewhere between 6,000 to 8,000 units of heparin, leading to a lot of wastage. To prevent the wastage, the multi-dose vial kind of practice is done. So this is again a mistake that we did deliberately to point out how the nurse is trying to carry the same heparin vial to be injected into another patient, which should not be practiced. So you can still reuse vials with precautions that you can. Heparin doesn't need to be refrigerated, so you can store it at room temperature. You can simply use a box to keep with a label to reuse in the same patient is one option, or you can prepare multi-dose in multiple syringes at a different center and then transmit these syringes to the patients. Okay, I'll conclude my talk because of lack of time, but I think I have done not more than 15 minutes. But anyway, so vaccinations, these are the recommended vaccinations for dialysis patients and healthcare personnel. And isolation procedures are only recommended for patients with hepatitis B virus due to the high risk of transmission and due to chronic carrier state, which is more common with hepatitis B. So an ounce of prevention is better than a pound of cure. Thank you for the patient hearing. If there are any questions, I will be willing to take.
Sir, our scenario, I will tell you, in most of the hospitals, not only in my hospital, dialysis has been used multiple times. Like it has been reused, in fact, for the same patient for multiple times, depending on the fiber bundle load and all the tests they do. So what is the practice right now? Are we reusing the dialysis, or it is not recommended at all as per the new guidelines?
Dialyzer reuse is definitely an option. In many units, they continue to reuse dialyzers, particularly based on the multiple factors, including financial considerations. In units which have practice of using, I have shown a machine, but I have not discussed about it, that's called a Renatron. Now, the process that has to be followed, including thorough rinse, followed by antiseptic locking, and while reusing, to rinse again and checking with a pH strip and checking for the fiber bundle volume. That means how much of the dialyzer is still retaining its efficacy to clear the toxins or uremic toxins. That is all set up in a single machine. So if you have the Renatron machine, I think its units can still continue to reuse the dialyzers, particularly because of the environmental concerns. The amount of wastage that is generated in dialysis unit is likely to be huge burden to the environment also, particularly the plastic wastage.
Measures.
Sorry, ma'am, I couldn't hear you.
Dialysis machine, in addition to surface cleaning, in between two patients, for the dialysis machine, what all precautions to be taken? How to internal
As
cleaning?
I have told, the dialysis machine requires 3 types of cleanings. One is after every patient, where the surface is just cleaned, because universal precautions are only recommended for hepatitis B. HCV and HIV, there is no, the isolation is only recommended for hepatitis B. So we don't isolate C and HIV patients. So in those patients, the risk of transmission will always remain. So surface disinfection is sufficient for that. Just using a bleach to clean the medical bleach to clean the surface of the machine should be sufficient. At the end of every day, again, internal disinfection with citric acid, and at the end of every week, internal disinfection with disinfectant of something like a medical bleach again can be done.
Okay. So only end of the day citric acid, no need of internal cleaning in between two patients?
No. Between two patients, it is mandatory to clean the surface.
Only surface.
Because surface contact is the highest risk of infection transmission in a dialysis unit. The linen has to be changed, bed has to be cleaned, machine has to be cleaned. It just takes a few, less than a minute if properly done by a trained person.
Thank you.
So what is the recommendation for this, sir? I'm here.
Sir.
What is the recommendation for this? Is there any recommendation to keep the dedicated equipments for HBV, hepatitis C and HIV when we are decontaminating the equipment aptly and also changing the dialyzers, taking care of the infection control practices? Do you still feel that we need to keep a dedicated equipment for the viral positive cases?
Hepatitis B, definitely, sir, because the risk of transmission is quite high, and the asymptomatic carrier state and the risk of having an insignificant infection which can be easily transmittable are very high with hepatitis B. So HBV, yes, dedicated machine is mandatory. For other things, it's not mandatory. But due to fear and the stigma, some units tend to practice having a dedicated machine for HCV and HIV as well, but recommendations say only for hepatitis B.
Even if the patient is completely vaccinated for hepatitis B and anti-HBs titers are more than 10 protective levels, still we need to follow all these things.
No, if the patient is infected with hepatitis B, he has to be isolated.
One patient is already infected, we have done dialysis on that machine. Now I want to take a next patient who is hepatitis B negative, but he is completely vaccinated with the anti-HBs titers is under protective range.
You're right when it comes to saying that once somebody is vaccinated with adequate titers, even organ transplantation is done from a hepatitis B positive donor to a hepatitis B negative donor. If he is adequately vaccinated, there is no need to worry about the virus. But when it comes to dialysis unit, ensuring that every patient's titers are high and adequate and maintained throughout is difficult. That's why the simple solution is to just isolate. But yes, you're right, sir. He is absolutely safe when it comes to risk of real transmission.
Sir. I just want to add 2 points actually with the doctor. First of all, first point regarding the reuse of the dialyzer itself. So when we talk about any reuse of any medical devices, first of all, you need to look onto the IFU of that equipment and how many times it can be sterilized or it can be reused or it can be reprocessed is mentioned in the IFU. So based on the IFU and the visible compatibility, when you see that there is no breaks and cracks in the device, till that maybe you can reuse those devices. Second point which was observed regarding the medication preparation. Now, how many nurses we have here? Can you raise your hands? Nurses. Okay, so whenever you are preparing your IV medications, whenever you are withdrawing those medications from the vial, do you know about coring? Have you heard about coring? We studied in our college days, but we are not practicing it. That's one main point. So what is coring? You can write it down, C-O-R-I-N-G. Write it down and go back and can refer it to the guidelines. It's mentioned, it's a very good topic to read about, how the infections can be spread through the coring of withdrawing the medications from the vials. So these 2 points I need to add. Thank you.